So hi, everybody. Thank you for joining us today. My name is Phil Larson. I coordinate veteran and military services at the University of Michigan in Ann Arbor. We have a week-long schedule of events for you for Veterans Week. I hope you've gotten a chance to look at them at our website, which is vets.umich.edu, and I'll put that in the chat once we get started. Just a couple of housekeeping notes. Right now I have your mics turned off, which is just for, so we don't have pets barking and kind of echoes and all that other normal Zoom stuff. I feel like the theater person of please silence your cell phones, but I have silenced them for you right now. We will be, since we have only right now about 14 total people in the room, hopefully we'll have a little bit more. I will be unmuting them for our question and answer session. Since it's a smaller group, we can do that. And so when it comes time, I will allow you all to unmute yourselves and ask some questions. So let's get started. This meeting is going to be recorded in case you didn't get the little blurb. I will also turn on the closed captions when I can find them after we get started here as well. But I wanted to, it's my pleasure to introduce Jenna Long, who is going to kind of be running the program from here on out. So thank you all. And Jenna, I turn this over to you.
Thanks, Phil, and welcome. I'm glad that so many of you could join us this afternoon. Again, my name is Jenna Long. I work for the School of Nursing at the University of Michigan, and I have the real honor of hosting today's session on lessons learned from the military service and how it can help in the era of COVID-19. To introduce you to our speaker, who is retired U.S. Army Colonel Patrick Ahearne, who also happens to be a UMSN alumni. Go Blue. Pat retired after 27 years of experience as a leader in the Army health system, culminating his service as the CEO of Wynn Army Community Hospital. As a military veteran, he has been able to apply many lessons learned in leadership concepts amid the COVID-19 pandemic. So today's presentation will cover topics such as planning, training, human factors, concept of mission, command, logistics, and personnel. So without further ado, Pat Ahearne.
All right, well, thank you. Good afternoon, everyone. I want to thank Jenna Long and the School of Nursing for inviting me here today. And I appreciate the opportunity to speak with all of you today. And I hope I can share with you some lessons that I've learned throughout the years in my military background, and as I transitioned into the civilian healthcare system as well. So just to give you a little bit more about my background, as you know, I graduated about 30 years ago from the School of Nursing in 1989. I had various assignments in the military throughout the continental United States. I do have 2 combat tours and a humanitarian service relief mission to El Salvador under my belt. Just to go along with kind of my background, I've got all the military education that the Army offered. They love to train us, give us a lot of leadership background and leadership courses. I graduated from the Army, the U.S. Army War College, as well as the Army Medical Executive Skills course, Command and General Staff College. So I retired back in September 2016, and since then I've served as COO and CNO in 2 of the largest civilian health systems in the country. So with that, I'd like to jump into what we're going to do today. The military healthcare has had a strong relationship with civilian healthcare for many years. They say that necessity is the mother of invention. Over time, military research and innovations have been adopted into civilian medicine. Way back in World War I, triage was used since World War I as a process of determining the priority of patients' treatment based on the severity of their conditions. This rations treatment efficiently when there are insufficient resources to treat everyone immediately. Blood banking became a common thing in World War II, as well as the use of penicillin. The discovery of penicillin, though, traces all the way back to 1928, but it really didn't see a mass use or mass production until the war started in the 1940s. And again, blood banking was also conceived in the 1940s, and many of the discoveries and developments in this field have been perfected to the modern blood banking techniques we use today. Further on in our history, Korea and Vietnam, we saw the advent of medical helicopters being used as your first medevac systems during the war. And as we all know, those are a commonplace in all of our health systems throughout the country today. Other advances in Vietnam were wound adhesives and hemostatic bandages. And we also saw the one-handed tourniquet developed during the Afghanistan war. So as you can see, the healthcare system, the military healthcare system has a strong relationship with the civilian healthcare system. And many of that is some of the research and innovations that we have learned throughout the years. For the last 10 months, our national healthcare system has been dealing with the challenges of COVID-19. Unlike a normal mass casualty event, the COVID-19 pandemic poses unique challenges to the health system and to the execution of healthcare. As a military veteran, I was able to use and apply many lessons learned and leadership concepts from my military background to my experience at Swedish Edmonds Hospital in Edmonds, Washington. Swedish Edmonds is a hospital, it's a community hospital that is about 12 miles north of Seattle. And unfortunately, Swedish was one of the first hospitals in the country to receive and treat COVID-19 patients. Our sister hospital up a couple miles up the road, Providence Everett, was the first one in the country to receive a COVID-19 patient. And from what we can tell based on our dates, our first positive patient we saw on the 2nd of March. So Edmonds was in this fight early and continues to this day. I would like to share some of my experiences, both in the military and throughout this crisis, and how my military lessons learned apply to the era of COVID-19. Well, Phil, I'm trying to advance the slides, and it's, oh, there we go. Okay, this is some of the topics we're going to cover today. Planning, training, some human factors, discuss some logistics and personnel, safety, security, communication, calm amongst the chaos, concentrate your forces, discipline, win this battle, and perfection is unobtainable. And we'll talk about those as we go along. Those will be some of the things we highlight as we go. First up is plans. Plans are nothing, planning is everything. Another quote from General Dwight Eisenhower is, plans are useless, but planning is indispensable. Many of us have been involved in planning sessions, especially ones related to mass cal planning or other contingencies. And it feels like they are just exercise in futility sometimes. You publish the plan and then it sits on a shelf and nobody looks at it until something happens. But what you don't realize is there's actually a lot of learning and absorbing going on as you go through the planning process. And as a leader, it helps your subordinate leaders to understand your intent. Those plans there tell your subordinate leaders what is expected of them during an event. Even though you don't necessarily feel like at the time that you're writing these things up and you're publishing them, that you're getting a lot of absorption from those leaders as to really what's going on. So when it is time to actually implement the plan amongst the chaos of the incident, things are mentally in place for those leaders because they at least have been part of that planning process. And the planning helps you through the uncertainty of what might be coming along. The other military phrase that is common is plans don't survive first contact. And that is very true. You plan for what you think are going to be the common incidences that occur, but you never know until you're in the incident what adjustments you might have to make. In the Army, we use strategic planning as well as operational planning, and that is very important. And it really became a part of our vernacular in working with the COVID-19 situation, because we call current operations is what you're actively doing. And COVID created a situation where we had to implement a COVID response, but then we quickly realized that this was not a short-term exercise. There was going to be a level of new normal that we had to figure out. So our planning took on a more longitudinal view. And it is a term that the Army uses when they say current operation and future operations. Once we had our current operational picture in place, we had to then start thinking about reorganizing. and our planning took on looking to the future. What was going to happen beyond COVID? Not necessarily beyond it, but once we got through kind of the peaks and valleys of what we were experiencing. So we started looking at future operations. My COO asked, hey, what are we going to look like, beyond our current environment? So answering the question of what is our post-COVID posture was something we just had to start thinking about. It was difficult for some of our core leaders, though, to think beyond the day. And you don't want your operational leaders necessarily to be involved in that longitudinal thinking. So we allowed them to continue to take care of the patients they were taking care of and do their current day-to-day operations. Then a small group of us looked beyond what we thought we were going to do when we started opening up new services. So the Army taught me how to think operationally, strategically, and balance the current environment against the future, and how we transition back to normal operations, or what we all are experiencing now, the new normal. So the next thing, as George Patton says, you fight like you train. The important thing that we learned and that really came into play is we had done previous training exercises on our, what we call our MassCal plan, or since we lived in Washington State, they like to train on possibly having, unfortunately, an earthquake. So we did a lot of training around that scenario. The good thing is, the hospital took their training very seriously and their exercises very seriously. The Army stresses this concept that you train as you fight. The more realistic the training, the less chance the soldier will react hesitantly in combat. So when you do your training events, make them as real as you can. Your training exercises need to be real, so if you make mistakes, you fix them in the moment, and those mistakes won't be repeated when you're in the middle of an incident or an exercise or actual event. Remember, we dealt with infectious diseases before COVID-19, so the basic building blocks were already there. We just needed to learn all the unknowns about COVID-19. Just like I said previously, your initial plan doesn't survive first contact, nor did our assumptions with COVID-19. Although we felt we had a 90% solution, we were adjusting constantly, to the point that the staff was getting frustrated because the truth kept changing, and we all experienced that with the news as well. Another key point in healthcare is that mass casualty situations or medical emergencies are more logistical in nature. What I mean by this is the medical care is actually the easy part. We know how to take care of patients. The doctors and nurses and the staff are all trained in their specialties. What is the challenge is the high volume of patients. So it becomes a challenge in numbers, in space and things like that. So most of our exercises, when you think back to them, how many times during a MassCal exercise do you actually practice caring for the patient? Most of the time it is moving those patients through the system, because it's a high volume of patients that you're all of a sudden receiving from an event. So really your exercises take on this act of managing patient flow. Now, of course, COVID-19 had plenty of new treatments and therapies to learn and implement, but the main concern still remained patient movement and bed management. How are we going to care for the influx of patients and do it safely? That is when the training kicked in. We had been through the exercises for high volume patient flow, and so we implemented what we knew. The Army has learned over the years that the Army is only strong because of the families that support our soldiers. So human factors are very important in incidences like this. With the stress of the unknown, it is imperative that we paid attention to our staff's morale and their mental health. There was a lot of unknowns. There's a quote in the Army: recruit the soldier, but you retain the family. Our clinical staff was equally concerned about the risks they may be bringing back to their families. And we had to reinforce that we deal with infectious diseases every day. And through our training and our processes, they would be safe, and subsequently, so would their families. You must be ready to address these stressors and provide resources to your staff. Luckily, our chief medical officer focused on wellness, and we provided a behavioral health concierge to be a resource to our staff. You must also be prepared for stressors to manifest themselves after the fact. We learned in the military that many stressors from combat manifested after the soldiers returned home. We will still need to watch for these types of stresses in our hospital staffs, even after things start to recover, because you never know when those stresses are going to manifest themselves in your staff. Now, I like this quote, and I know it has a little bit of humor to it, but my logisticians are a humorless lot. They know if my campaign fails, they are the first ones I will slay. Alexander the Great. As I said before, without logistics, you have nothing in the hospital. Logistics is everything. Without supplies, without equipment, the clinical staff cannot do their job. You got to think about the volume of line items that a hospital requires. It's in the hundreds of individual pieces of equipment and supply that you require as a clinician to care for your patients. And hospitals are some of the most complex organizations there are to operate. And medical logisticians are priceless. We all have heard throughout the country about the PPE shortages, and many hospitals had difficulty keeping their supplies intact and are still having those challenges today. We did implement conservation practices at Swedish, but luckily we never ran out of any of our critical PPE supplies. And this highlights how leaders need to make calculated, or we never ran out of our critical PPE supplies, but it highlights how important our logisticians were. Though as leaders, we did make some critical conservation decisions, which was sometimes uncomfortable for our staff, and many of those have been highlighted in the news. Prior to COVID, we would have never have thought about having anybody use an N95 mask more than once. We live in a disposable supply society. Now, though, through this experience, we have learned that if properly maintained, we can use an N95 safely more than once, and we did that. And luckily, we have not had to this day any exposure due to a failure in any of our PPE equipment that we've used. We also have heard about lab testing, and lab testing took on a logistics theme as well. Due to the rationing of reagents, we had to make certain decisions about who we test and how we test. We also determined not to use some of the rapid tests due to their false negative rates. So the bottom line is logistics will be and should be a central focus in all your contingency planning and contingency situations. And as a leader, you need to be very involved in the logistics planning. Leadership is not about being in charge. Leadership is about taking charge, taking care of those in your charge. So I did talk about the human factors previously, but now I just want to talk about people in general. I separated human factors from people so I could stress the importance of thinking beyond the individual and the broader impact crises have on your staff, but then the need to bring it back to day-to-day personal safety. The Army uses a concept called a battle buddy. So your battle buddy is responsible for you and you for them. The key point is, if you don't protect yourself, you won't be able to take care of your patients. So this concept took on a new meaning with COVID-19. And we recognized the risks that our staff was going to be under as they cared for these patients. So we created something called a COVID monitor. Much like a battle buddy, the COVID monitor was there to make sure that people took care of themselves, were responsible for how they used their PPE. They were there to monitor them to make sure that they donned their PPE properly and that they maintained good technique. This not only protected our patients, but our staff as well. And it turned out to be a really, really good position that we created, because we found that these people kept us safe. And it's most important to keep your people safe during incidences like these, because if your staff start to go down, then your ability to provide medical care is diminished as well. The other key thing that you need to think about is you need to keep track of your leaders, and you keep an eye on yourself. Losing a leader is demoralizing to any team. My COO and I became battle buddies, and we ensured we each took downtime to recharge. And we would keep an eye on one another throughout the event because we were working sometimes 24 hours a day at the beginning. And we realized very quickly that we needed to kind of break each other from that event. Safety and security. The first thing an Army unit does when it lands in an area of operations is establish perimeter security. Due to the COVID-19 virus, we had to secure the hospital as well. And this was uncomfortable for a hospital all of a sudden to shut down from visitors and other people who needed access to the facility. But due to the nature of the virus, it was important that we limited our visitors and we started screening our staff as well, because you had to protect the actual physical environment as well as the people working within the physical environment. We established entry control points and limited access to the hospital, so all visitors and staff were funneled through set entry points. At first, we didn't allow any visitors, and I'm pretty sure that was kind of the norm throughout the country. But over time, we adjusted. The staff understood the importance of this, but also created some emotional challenges for them as well. Taking care of patients who are dying from the virus without families is emotionally draining. Although if death was imminent, we tried our best to get the family to the bedside, but we couldn't always make that happen. The bottom line is you have to make sure your soldiers and staff are safe and secure so they can do their job. The difference between mirror management and leadership is communication. Communication was critical to what we did each and every day. There was so much information to put out that we couldn't over communicate. And as a leader, you really can't over communicate. Your staff is dying for information. They want to know what is going on. And communication is the only way that you could do that. All forms, electronic, written, verbal communication, whatever it takes to get the word out. But communication matters most when everybody is in a hurry, because you need to be able to communicate changes in what we were doing. And there was so much new information coming out on a daily basis that it was critical that we put information out in timely. But one of the things we did learn is that the timing of when you release that information was critical as well. We never changed anything or made a new process or procedure on a Friday afternoon, because going into the weekend, your resources to your staff are going to be less. And if they had any questions about those changes, you didn't want them having those questions at a time when the availability of people to answer those questions was diminished. So we learned to put out any new or any changes in our posture or any changes in our procedure. You put them out on a Monday or Tuesday, and it gave you a couple days during the week to perfect or answer any of the confusion that might have been part of that communication prior to the weekend, when staff would come in and maybe not have been present when that word was put out. The other important thing for communication is sharing the why you were making certain decisions, why we weren't using certain lab tests, why we weren't changing our posture when maybe they heard from a staff member of the hospital down the road. They may have been changing the way that they did something, and the staff would want to know, why were we maintaining our posture? So sharing your why is very important as well, because you wanted your staff to have the same common operating picture as you as a leader did. So that became critical as well. As with any of these types of events, chaos is coming. It's part of the event. But as a leader, and what I learned through the military is the leader needs to stay calm amongst the chaos. You need to be the calm beacon that puts out information in a way that people are not alarmed by the way you're behaving, by the way you're responding to something. Something I learned early on, especially when we were deployed, we thought this was something we learned downrange, is there's no such thing as an administrative emergency. There's just not. You have lots of questions that come to you as an administrator, as a leader, but emergencies are when someone stops breathing. So as a leader, you always had time. You always had time to think. And even though your staff wanted an answer quickly, situational awareness is paramount. Taking time to critically think was important. You always have 10 minutes to think. Hurry carefully. You have time, because you don't want to make a bad decision, but you also can create a bad situation with indecision as well. So take the time to think. One of the things we learned was in the middle of a mass cal situation downrange, and the trauma room was getting loud, and the volume was going up. The volume was going up. And all of a sudden, one of our docs, Dr. David Steinbruner, a fabulous ER physician, gets everybody's attention. He's like, hey, everybody, listen to me, listen up. And he reminded us, he says, it is not our emergency. It's the patient's emergency. We need to stay calm because we need to take care of this patient in front of us. And it was kind of just, all of a sudden, everybody just got it. It was such a profound statement because we realized we were allowing ourselves to get our energy up in a negative way. And he quietly calmed us back down and recentered us. If you're going to use military force, then you ought to use overwhelming force. Use too much and deliberately use too much. You'll save lives, not only your own, but the enemy's too. This is General Curtis LeMay. And this statement, what this statement means and how I translate this into what I've learned or what I take from this from my military experiences is the military masses their forces, concentrates their forces to punch through a battle line or punch through the enemy. And how does this translate to COVID-19? Well, with COVID-19, this translated to concentrating the location where we admitted these patients. Because you didn't want to admit these patients all over the hospital. Then you'd have these infectious patients in various places, and they'd be traveling throughout the hospital. So we concentrated those patients in 1 or 2 units. And this proved to be a tremendous opportunity for us because it limited the amount of patients we had to train on all the new procedures. It limited the patient's travel throughout the hospital, so it limited exposure to other places of the hospital. And it decreased our chances of errors. So what we did is we took one of our ICUs, our PCU, and our med-surg unit, and that became the place where we concentrated all of our COVID patients. So we didn't have to train everybody in the hospital on all the techniques we were using with the COVID patients. Although everybody already knew how to take care of infectious patients throughout the hospital, we wanted to make sure that we focused and concentrated our patients in one location. And it turned out to be critical. And I think it really impacted the success we had with treating these patients and the success we had with zero cross-contamination amongst our staff and zero cross-contamination amongst patients. So from our experience, it worked out very well. Discipline. Discipline is the soul of an army. It makes small numbers formidable, procures success to the weak, and esteem to all. Soldiers are trained to be disciplined and follow orders and policies. Equally as important was the training our staff, the discipline our staff had with masking and use of PPE, their social distancing, following good hand hygiene, and discipline at home as well as at work. The majority of our exposures that we had in our staff were not within the hospital itself. Actually, all the exposures that we experienced as a health system from our people were from them being exposed outside of work. We studied this, we kept track of it. Anybody who came up positive, we knew who they were. And we followed them, and then we tried to figure out and did our due diligence. Where did they get exposed? But the discipline that they showed at work, if they showed it in their home life, proved invaluable. It meant they kept themselves safe. and also their discipline at work of following the techniques that we taught them, following how to use good hand hygiene and good technique was critical in the level of care we were able to provide. So as we think about what I talked about before in our training, if you're disciplined in your training, you're disciplined in your techniques that you teach and ensuring that people follow those, then you're going to, again, maximize your staff, because you're going to prevent any staff from being knocked out due to being cross-contaminated with COVID-19. So again, this goes back to safety as well. Another thing that the military, and this happens to be a quote from Margaret Thatcher, but it applies to the military as well. You may have to fight a battle more than once to win it. Well, as we have experienced with COVID-19, this is not a single day, a single time event. This event is longitudinal. We're going to be in this battle for a long time. In the military, you completed one mission at a time, then you needed to be prepared both mentally and physically to go out on the next one. Well, COVID-19 is just one mission, but this is not a sprint. This is a marathon. So we must prepare and coach your staff so that they will win this battle and get through the COVID crisis while maintaining their mental and physical health and being prepared to continue to work. We don't have the luxury as healthcare providers to really get a down day. You get a day off from work, but you're always in this fight. And this was even true in the military, because when we deployed, we were taking care of patients that when we returned home, we would see those patients again. Once we went back to work in our hospitals back here in the United States, we were still continuing to care for those same patients that we may have seen while we were downrange in a combat environment. Hospitals don't close, so healthcare is constant. So you need to ensure that you're keeping your folks focused on their mental and physical health, because they're going to be in this battle for a long time. A good battle plan that you act on today can be better than a perfect plan tomorrow, or a perfect one tomorrow. And this is an important point for many leaders to learn, is perfection is unobtainable. Common sense decision-making actually works. Good enough, it's good enough. Delayed decisions cause more disruption in combat and can get people killed. And that is taught often to our combat leaders. Make a decision, make a plan, and move on. Because the longer you wait, you give an enemy an opportunity to recover or to prepare themselves. Your staff are looking for guidance. Your people are looking for guidance. Give it to them. The more you analyze and hem and haw, the more distrust you sow in your ranks. They're wondering, do you really know what you're thinking, or do you really know what the answer truly is? Yes, the decisions we made were tough, but the staff felt reassured with guidance. And even if you had to make adjustments, which were many, knowing that you were there to make those decisions made the staff feel confident in your ability to guide them in the right way. So my guidance to anybody out there is, don't overanalyze the situation. Gather your information, use your good common sense and your critical thinking, and make decisions. So with that, these are some of the things I wanted you to take home today. Plan some more, then plan again. Train as you fight. Address the human factors. Logistics is key. Safety and security are important. Communicate. Leaders must stay calm in the chaos. Discipline is strength. And mental and physical health are key. So I want to thank everybody today for letting me share the few key points that I shared with my experience in the military. As we know, this is our Veterans Week, and today and every day we are grateful for our military and our service personnel. And I want to thank those who are still out there serving, my comrades that are still in the fight. I think of them every day, and I hope they're doing well and continuing to support us, and we continue to support them. I want to thank the School of Nursing for allowing me the time to speak with you today, and I'm very glad to answer any questions and go beyond what we talked about today. If you have any questions about my experiences in the service as well, I'd be glad to answer those. My combat experiences, I'd be glad to discuss those as well. So with that, I open up the floor to questions.
And everybody should be able to unmute yourselves at this point in time.
Hi, Pat.
Hey, there's my battle buddy.
How you doing?
Good,
to
good.
see
How are you?
Hey, thanks for the great lecture. I was wondering, can you post the slides, or can we get the slides?
Sure.
Jenna?
I think Jenna has them, so I think if we can send them out, yeah, anybody can share them.
Yeah, that would be great. Pat, one thing is that I'm working on like the resurgence plans here for the University of Michigan Hospital.
Mhm.
And do you have any advice for the battle buddy concept? Because I think folks are getting weary.
They are.
And
Mhm.
and in the military, like, remember, like, if you were like deployed or at Fort Polk or something like that, and they're like, oh, you have to stay a week later. That was like the worst thing that could happen, even though it's
Yeah.
not even that much time, but it's just such a, but how can you give us some advice on kind of preparing the force for what we may be seeing?
Yeah, well, the thing is to be open and honest. I mean, what we did, and I met with the staff that we centered our COVID patients on, my ICU, PCU, and our telemetry staff. We met with them often. We met with them frequently. We didn't sugarcoat anything. They're in this for the long haul. We really stressed self-care.
Yeah.
We really pushed our behavioral health concierge. I mean, we have a phone number. We established resources for the staff to say, hey, here are people you can call that are there 24 hours a day, ready to listen to you, be there for you, support you through this. But they also need to see us. They needed to see me. They needed to see our other leaders. So I would meet with them frequently. Hey, how are you doing? How are things going? Especially early on when we were having our first deaths without family. Oh, that was just debilitating. It was just devastating.
Yeah.
And you could just feel the emotions in your staff. They took they became that person's family. They stood at that bedside for that person when the family couldn't make it. Now, we quickly realized we needed to change that. As soon as our staff said to us, family need to be at the bedside, we went, yes, they do. We didn't say, hey, there's too much risk. We felt that the risk was warranted for the emotional health of our staff.
Yeah, thanks for doing that. I agree.
Yeah. And so we were actually one of the first hospitals to open their doors up and say, hey, we're bringing visitors back. Now, we limited it to one. We brought single visitors back. But when we knew a patient was not going to make it, if we knew, and the nurses got really good at predicting this, we would bring multiple family members. Hey, you need to bring in a core group of family to be here.
Great. Thanks, Pat. How did you operationalize that Batty Buddy concept?
Well, we through a monitor, through the COVID monitor. So every shift we had somebody who was assigned. So we staffed up. So we said, hey, if it was in the ICU, it was every 2 to 3 patients, there was a COVID monitor who could monitor the staff that went in and out of those rooms.
Were they a nurse or a social worker, or?
It started out to be a nurse, but we got some other staff involved. And ironically, we actually had our unit clerks that were in those areas became so knowledgeable about COVID, we could teach them, and they became great monitors because they were detail oriented. And actually, we at some point had had unit clerks serving in that role as well.
Wow. I
And
kind of like the multidisciplinary
yeah,
group on that. That's really great. I'd like to know more about that, maybe offline. That
Now
sounds like a, did you write an article about that, Pat? That should be your.
oh. Now we also did you've been hearing about, you know, the one of the things we did, like especially in the ICU, is, you know, we put the IVs and IV poles outside of the room, and we strung those lines, and so the staff could change those frequent medications and change those bags without having to gown up. So we tried to limit as much entry into the room as we could to decrease that. Now we also did a respiratory therapist, because remember, respiratory therapists are, man, they are a force multiplier, but they're not a large part of the staff. You know, there's one respiratory therapist for like 10, 12 nurses. Well, you didn't want that one respiratory therapist gowned up and in a room when they had to monitor multiple patients. So we started kind of hey, the therapist would stand outside the room and the nurse would communicate with them vent settings. And then they would dictate to the nurse, hey, make this change, make that change, to keep them from having to go in and out multiple rooms. You know, so we changed that kind of communication as well, which turned out it worked well, but it was different.
And then finally, something we don't always do in the military, but we do have like hazardous duty pay. Did you incentivize any of those nurses that were on the front line, or?
We did not. That was a point of contention with our union as well. They you know, wanted that, but again, everybody was going to be in this fight. So that would have been, you know, the whole staff. That would have been everybody, you know.
And then the unit clerk, the monitor, the
everybody was involved. Yeah.
Mm-hmm.
So we chose not to do that, though we never laid anybody off. We kept everybody whole. We kept everybody, even when we shut the OR down, we kept the OR staff and everybody. We brought them in to be COVID monitors. We brought them in to be battle buddies. You know, we kept them employed. So we did the best we could to keep the staff whole as an entire unit.
Well, Pat, it sounds like you did such a great job, and it was so good hearing from you today. Thanks for coming back to, you know, Michigan to talk with us today about it. I'm surprised that they let you go. I'm surprised they didn't say, don't go back to Michigan.
I was on a
vote in Michigan, maybe. I don't
know.
My
3-month contract, I was on a contract out there. It was a 3-month contract turned into 10 months because I didn't leave during COVID. I was supposed to be done in March. But I did. I had 2 weeks overlap with the previous CNO. So I just actually handed off the reins to a new chief, and she took it over from there. But yeah, I ended up staying out there quite a bit longer than we intended. So
gosh, well, they were lucky to have you, and thanks for sharing the lessons learned with us. I think they're even more, the timing is perfect for what we might have to deal with.
No, I think with the resurgent and everything that we're seeing with the numbers, there's, you know, everybody's back in this fight. And you know, I was tracking kind of the university hospitals numbers because I was kind of curious what was going on back in Michigan while I was out in Washington. And you know, we peaked a lot earlier than most because we were in it early. But I was, you know, it was funny. My little hospital saw quite a bit of patients. It was an interesting experience, and one that'll go down in the history books. But I'm really glad I had my background, because it really made kind of the operationalizing of this a little bit easier for me, and able to share that with the staff at Edmonds. So.
Great. Thanks again. It's so good to see you, Pat. Look forward to catching up with you.
Great to see you, Greta. Thanks.
Bye-bye.
Okay.
Well, I have a question then.
Sure.
Question. I know this was a lot on like hospital staffing and healthcare specific. But for both civilian as non-military folks who are out there, but also civilian as non-medical staffing people out there, what can, knowing what you know, military background, and knowing what you know from healthcare background, what can we do as a larger population to, as we get into second wave, to help control this, to help support each
That's-
other?
It's a great question, Phil, and really, it's what we've been hearing. You know, the masking, the social distancing, good hand hygiene, taking care of yourself, all of that. That's very doable for us as a community, and it's critical. It's critical to our success. I mean, I share it this way. We mask and wear masks in hospitals every day for other diseases. This is a known thing that we do to protect ourselves. This is not new science. It's just we're expanding this to outside the walls of a hospital. So really what it is do the basics, and take care of one another. If you know people who are in the healthcare field and reach out to them. Just knowing that you're there and supporting as a community is critical. I mean, we would have community members deliver us, they wanted to feed us all the time, which is wonderful. But just knowing that they're there and that they're thinking about you made the staff's day. People who would come to the hospital and put signs up in our parking lot, basically, or in our area, as staff came in and out of the hospitals, they saw those words of encouragement. I mean, those are all things you can do as a non-healthcare provider. But taking care of yourself, taking care of your family, and doing what we ask, and doing what our community health professionals have put out there, our public health professionals. That's how you can honor us, and so that's what I would share.
Thank you. Yeah, I mean, I reflect on the thank you for your service mantra we get for veterans, for being veterans, and I want to pass that on of like, thank you all for your service that you do for patients and helping people get better, and helping other people and their family members who can't. And so thank you so much for all you do for everybody. I want to appreciate that.
No, thank you. And it is, thanks goes a long ways. Those small words actually have a profound impact on staff. It really picks them up, and it's that simple.
I liked when you said that, you can't save people if you're not healthy yourself, right? And when you were mentioning about mental health and taking care of yourself and that fine line between caring for yourself and your own families, but not exposing, right? Because like you mentioned in the beginning, how most of your exposures didn't come from being in the hospital. It was, being at home or, going out and about. And so there's just such that fine line, that gray area of doing things that keep your emotional and your mental health, your physical well-being, but also being mindful of your exposures. And it's just such a delicate dance, it seems like. And work. And I see that also in working with my graduate students who are all on the front lines as nurses and going back to school as nurse practitioners and midwives. And it's like, how do you juggle that gray area,
Right. No, and it was really, I have to give it credit to the Swedish or it's not corporate, the Swedish system. We had twice a week incident command calls with the system. So we have 5 hospitals in the system. And there was a standing line item on our agenda as leaders every call about the well-being of our staff. What are we doing for the well-being of our staff? So it was really a kind of a neat thing to participate in, because it was something that, of course, I knew, and I would do in the military, but to see that operationalized at that level was refreshing for the staff. And as it turned out, from the contaminated staff, our numbers were great. We had less than 1% of our staff exposed and taken out of the fight for a while. So it actually, everything we teach and train, it works. But their health and their mental health was critical to that as well.
Absolutely, because like you mentioned, it's not a marathon, it's a marathon, not a sprint, and that would go as well as the physical and mental well-being, right? That this isn't a temporary challenge that we're experiencing, that this could go on who knows? I don't even want to try to project, but hopefully not as long
Yeah.
as we.
Hopefully we're turning the corner, and hopefully that
Yeah.
vaccine, the vaccine information that's coming out sounds pretty good. So we're looking forward to that.
Right. All right. Well, Pat, phenomenal. Really appreciate you and your work that you've done and continue to do, and your willingness to join us back this afternoon for a session. We're certainly grateful for you, for your service, and for your continued service. And I absolutely look forward to more opportunities to engage with you and hear from your expertise. And so it's good to connect with you and
Yes.
to have that shared knowledge. So.
Well, thanks,
you.
Jenna. Please let me know if there's anything else you can do. I'd love to come down and talk to other people and be
Absolutely.
available to you. And thank you for the opportunity to speak today. And have a great week, everybody.
Absolutely.
Yes.
So everyone, thank you for joining today. Pat and Jenna, thank you very much for this program today. It's awesome. I want to let you know, Jenna, that we had about 15 people at our height. But that is like so many more than we've ever had for a kind of a medical panel for Veterans Week. So we're doing a really good job on this, and love to have this continue this year. I'm always recruiting for the next year. So this would be great to continue this discussion. And Pat, maybe we can have you on something afterwards, kind of talking about looking at COVID-19 through the lens of history rather than in the trenches.
That would be great.
All right. Thank you all very much for joining us today and participating. Thanks for everybody who joined us during your lunch hour. We hope you are going to continue to watch a couple more things during Veterans Week. Take care, be safe out there, and go blue.
Yes, always go blue.
Go blue.